The uncomfortable truth about giving NSAIDs before surgery is that both sides of this controversy are partly right. Giving them early may improve pain control. That's a plus. But giving them before anesthesia may also remove one of the kidney's protective mechanisms at the exact moment blood pressure is most likely to fall. So, why give them before surgery? Well, NSAIDs reduce prostaglandin production and help control the inflammatory component of surgical pain. Administering one before tissue injury means the drug is already working when inflammation begins. That fits the modern concept of proactive multimodal analgesia. Treat pain before it becomes established rather than waiting for the patient to hurt in recovery. So, why wouldn't we always give them preoperatively? Well, there's the kidney controversy, and this is an important one. Prostaglandins do more than create inflammation. They also help preserve blood flow through the kidneys, particularly when circulating volume or blood pressure decreases. During anesthesia, hypotension, even a little bit, is common. A patient may also be dehydrated, lose blood, or have underlying kidney disease that was not obvious on the initial examination. So, if a nonsteroidal anti-inflammatory drug has already inhibited prostaglandin production, the kidney may have less ability to compensate for reduced perfusion. But what does the canine evidence show? Here's where the debate becomes a little more nuanced. Studies in healthy, well-hydrated dogs have not consistently shown clinically important renal injury from appropriately dosed preoperative NSAIDs. For example, one controlled study found that preoperative carprofen did not significantly worsen measured renal function or hemostasis in healthy dogs undergoing anesthesia. But that does not prove preoperative NSAIDs are safe in every surgical patient. Most studies involve carefully selected healthy animals with fluid therapy and monitored anesthesia, not dehydrated emergency patients and septic animals and dogs with occult kidney disease or patients experiencing prolonged hypotension. Now, why some veterinarians wait? Well, some anesthetists prefer to administer the NSAID after surgery once they have confirmed that blood pressure remained acceptable, that there were no major hemorrhage events, that renal perfusion appears adequate, and the patient is recovering normally. So the trade-off here is that the patient may not have had therapeutic NSAID concentrations during the earliest phase of surgical inflammation. Now, why other veterinarians give it beforehand? Other veterinarians administer NSAIDs before anesthesia in young, healthy, adequately hydrated patients because it provides analgesia before tissue injury. It may improve early postoperative comfort. It avoids delaying an important component of multimodal pain management, and evidence of harm in carefully selected healthy patients is limited. Now, my practical approach, this should not be a rigid rule. It should be a risk assessment. For a healthy elective patient with normal hydration, appropriate screening, IV access, fluid support, reliable blood pressure monitoring, preoperative administration may be a reasonable choice. But I would be far more cautious in any patient with dehydration or hypovolemia, known kidney disease or questionable renal function, hypotension, sepsis, shock, significant blood loss, gastrointestinal ulceration, or concurrent corticosteroid or another NSAID being used. In those patients, delaying or avoiding the NSAID may be a much safer route. So the controversy is not really NSAIDs before surgery, good or bad. It's whether the analgesic benefit of giving the drug early outweighs the renal and gastrointestinal risk in that individual patient. Preemptive analgesia matters, but so do hydration and renal perfusion and blood pressure monitoring and patient selection. The best protocol is not based solely on the clock. It's based on the patient in front of you. I'm Dr. Steve Mailer, and I read the papers so that you don't have to.